All right, look, my topic, I'm looking at everybody's topic and I've been talking about this area. I don't think it's the most sexiest topic, to be honest, but it is an area of significant importance. And as a cardiologist, I find myself uh, as a lone voice trying to push this topic, which is probably more prominent among non-cardiologists. So it's chronic disease self-management and heart failure. Uh, the term, in fact, I was writing an article quite recently with a colleague about, it was a systematic review, and I put in the topic chronic disease self-management and heart failure. And one of my colleagues who is in public health said to me, he said, why would you put such a combination together? It's self-management and heart failure, right? You know, and the fact that he thinks chronic disease is separate uh, entity to heart failure. Heart failure is a chronic disease. It just happens to be a cardiac version of that. So heart failure is the most common cause for hospitalization in adults over 65 years of age. And the issue with this is cost. It's a lot of money to admit someone. Heart failure goes through stages from mild to severe, and in between those stages is you can get decompensation, stable stages and decompensation. The mild stages are usually controlled with drugs, diet, fluid restriction. The hospitalization stage, you get emergency admission, bed rest, oxygenation, morphine, intravenous therapies. And of course, the severe end stages where you either palliate patients or use more advanced therapies. And the number of transplantations that are done, particularly in the current state I am in Australia, is only 20 to 30. So the amount of infrastructure that goes in for 20 people and the medications is actually quite substantial. So we do also have to have a preventive role for this. Now, looking at the epidemiology of heart failure, it's a clinical syndrome, and it can result from any structural or functional disorder that impairs the ability of the left ventricle to fill or eject blood. Now, we all grew up with the understanding that heart failure is a syndrome. Yes, it is a syndrome, but it's also now a disease, because if you have ischemic heart disease, it's no longer heart failure, it's a syndrome, it's a disease. It's ischemic cardiomyopathies. So we are changing some aspects of the epidemiology, and the terminology should follow. The syndromes actually come really in aspects of care which are in the chronic disease segment, like rehospitalization. How do you prevent rehospitalization? There are actually no answers for a lot of these questions. 5 million Americans can have heart failure, 500,000 new cases a year. The cost is about 25 to $50 billion a year. There are about 6.5 million hospitalizations and 300,000 deaths per year. The risk factors for heart failure: ischemic heart disease, smoking, blood pressure, obesity, diabetes, and variable heart disease. Now, the reason why ischemic heart disease has a very high relative rate is because it's a disease. Okay, where smoking and things like that are syndromal in that they lead on to disease, and it depends on associated comorbidities with that. The populations at risk, if you have ischemic heart disease, to getting heart failure is high, whereas for the other comorbidities, they vary between 2 to 17%. Okay, this slide basically shows the common denominators for heart failure. So whether you have hypertension, diabetes, ischemic heart disease, metabolic syndrome, renal failure, rheumatic heart disease, atrial fibrillation, there are several factors that are in common. Age can usually in isolation cause uh, heart failure. Reactive oxygen species, nitric oxide, sympathetic nervous system, they all have variable contributions depending on the disease states and the severity of those states. Okay, so what really is the problem with heart failure, and where does self-management come in? There's variable severities of heart failure. So you got people who are mild, who are moderate, who are significant, and you need to tailor services based on who uh, and who can self-manage and who can't self-manage. There's an increased comorbidity burden. At least 1 in 2 patients will have a comorbidity. They require post-discharge services. And obviously the geography and demographics, as you live further and further away, as your communication skills are less, you have cultural requirements, the ability to comply with one modality of treatment, which is basically the Western paradigm of treatment, uh, can vary. Now let's look at a scenario here of 3 subsets of patients. In fact, one of our patients before spoke about Africa. And it's interesting to note, just like Australia when she said you're in the south of Africa versus the north of Africa. Now, I'm sure there's a tremendous degree of diversity in Africa alone, and she's in Saudi Arabia, where the culture and things are very different. And obviously, there are populations in the southern parts of Africa. We have a more Western sort of lifestyle. So the solutions or treatments are very similar, but the cultural spectrum even in one continent like that is so diverse. So we have here a 55-year-old gentleman. So he lives remotely, lots of comorbid conditions. Now the issue is, you look at regime 1 here and regime 2. Now a lot of hospital formularies will store 2 or 3 medications which are preferred for heart failure. So let's say for a heart failure class beta blocker, many hospitals will store 3. And the 3 that have been stored predominantly have been carvedilol, bisoprolol, and controlled release metoprolol. Now, nebivolol is proven for older people. It's not available in a public hospital setting. And if you look at the advantage of nebivolol in someone who's, say, indigenous, who has renal dysfunction, who has metabolic syndrome, it is the only other comparison of a vasodilator beta blocker compared to carvedilol. So if you have nebivolol, which is not available, and carvedilol, which is available, now that alone becomes a difficult point in discussing treatment options. So if you have someone living close to the city, carvedilol is a good option. If you're having someone live far away from the city and who is only probably would benefit from taking medication once a day, the formulary is not reactive to this. The other things which are not in public system formularies are things like coplavix. In the private system, they are available, so you have to have aspirin and clopidogrel as separate things. Viagra is not available when you're using it for non-pulmonary hypertensive indications. Metformin is as a short release rather than a controlled release. So there are fundamental differences in regimes in public systems and outside public systems. So you can have a patient who has the most requirement for a simple regime having 15 medications over 3 doses. And you have to teach these patients how to understand to use these medications. And I go to the last patient here, a Caucasian gentleman who's actually quite sick, who's got 30% ejection fraction. Now he lives in an urban area. So I mean, this doesn't actually have to be a Caucasian. Basically, you can just say urban, right? Someone who lives in the urban environment. They are exposed to either formulary because they're exposed to the private sector and the public system, and they can vary and go to a shorter dose or a more a larger dosing regime. The other advantage of having choices in treatments is every class of agent has secondary benefits. So if you look here at perindopril as a choice of ACE inhibitor, now trandelapril has evidence, ramipril has evidence, lisinopril has evidence. Perindopril does not really have a lot of evidence for heart failure, but it is an ACE inhibitor. I think, in fact, one of the studies was done was probably in South Africa, which used perindopril in one of their studies. Now, perindopril, however, has indapamide attached to it. So you have now the advantage of having a diuretic to your ACE inhibitor, whereas if you start with ramipril, you don't have that advantage. And perindopril also can be combined with amlodipine, another calcium channel blocker, which you have when you have hypertension as an issue. And if you look at the beta blockers, the vasodilating beta blockers are carvedilol and nebivolol. Among the angiotensin receptor antagonists, telmisartan has the strongest activity against diabetics. Should be the treatment of choice, along with ramipril due to pipa gamma activation. Eplerenone is an alternative option for those who have side effects from this. So the dosing regimes are also important. Now, coming to self-management, how this all fits into the patient. So you got a patient and you got to teach them how to manage the care. You want to keep them in hospital, you want to keep them emergency plan. So the first thing is, let's talk about an emergency plan. So you give them an option, look, call the doctors before you go to hospital and give them some options to do that. So that's the emergency plan that you got to figure out. Then is, how do they understand their medications? So it's got to be simple, it's got to be easy to use, and how they action care. Now, when you factor that into the taxonomy of how diseases are, I think Harlan Krumholz wrote this in 2006, where you have the patient population. And as you can see, there's a whole spectrum of things you need to go to when looking at patient populations. The recipient. The recipient can be twofold. It can be the patient and the caregiver. In fact, I saw someone today, he was 75, he had bypass, he had valvular heart disease. So I was just sitting there and talking to them and asking them about stuff. He seemed to, I was just asking how much you know about your treatment and stuff. And the wife answered a lot of the questions. So I said, why are you answering a lot of the questions? And she said that, I look into his care. And she doesn't look into his care because he's invalid, because that's a partnership, that's a team, right? I think a lot, whether it's a culture or not, things, people function as a team. So the caregiver is potentially a partner and also a recipient of care, so which we have to factor. The content of the intervention, okay, and what languages you do it, the simplicity in which it's been done, updating that information, the delivery personnel. I mean, we all expect it to be the doctor. I mean, the nurses are there to bandage wounds and they've got different profiles, but eventually they do what's the most difficult task that nobody can do, which is helping bandage patients up and then send them out. Even if they do educate patients, it's very rare for you to be able to reinforce this. If you look at all the kids that we send to school, it takes them 12 years to come out of high school and get their education. Patients get 1 or 2 goals, and they're expected to navigate the system from that. And the method of communication, face-to-face, telephone, I think this part is not really so important as long as it's repetitive and it reinforces the issues. Intensity and complexity, that I think I just mentioned that. The environment in which it's done. With COVID-19, this is changing a lot, and obviously measuring outcomes. I think the single most important outcome for us to measure is readmission. I put that even beyond mortality. And the second part obviously is quality of life and understanding your medicine and delivering optimal care. Because I think if you get the readmission part right, you must have systems in place to answer those other questions. All right, so again, a busy slide, just took it from an article we wrote. What are the components of chronic disease management? Education is very, very important. And this is education staff and educating health systems. Now, in our health system, again, within a small sector of a state, we have 2 or 3 different providers of rehabilitation, and none of them have a standardized version of self-management. So the language in which even the health system people are speaking is very poor. The contents and the skills, again, it depends on what the health service provider thinks is important, isn't it? So it's a very subjective thing. It's not standardized at a higher level, like at a college level. The intensity and duration we spoke about. How do you assess a patient's improvement? I think this has to be very, very simple. The capacity to engage care is to be high up on that list. If they know what to do if they're in an emergency, that negates a lot of problems. The people involved, and this cost is a factor. If you can get a nurse, you're lucky. If you can get all those other things outside hospital systems, they're all working independently as private practitioners. So hospital-based care is ideal, but not everyone can access that care and for indefinitely. And finally, I mean, we've looked at a whole bunch of systematic reviews and things like that. Surprisingly, the evidence is actually quite scarce, and the evidence is actually not even proven. The Canadians have done a lot of work on this. In the African continent, it's the Iranians. Obviously, you know, they're smart people. They like numbers and stuff. They worked out the math of keeping people at home. So they've invested in that area as well. But a lot of others, I think it's been very much of very acute. If someone comes in sick, it looks very good to patch them up and send them home. But the longer term planning it's been generally quite poor. So in summary, chronic disease self-management in heart failure has some evidence, but it could be improved. Chronic disease evidence can be interpreted in many ways. Regardless, it is vital to build self-management skills in patients to reduce the epidemic of heart failure on patient outcomes and costs. So yeah, that's it.
Wow, I must say this is a very good topic, because in practice, this is what we see. This is what we see: patients with ice cream buckets full of medication. And sometimes I don't even know why. And they don't understand certain diuretics is potassium sparing or not potassium sparing. They complain a bit about side effects, but they don't know what to do about that. And with COVID, unfortunately, COVID is now the topic. So our patients, it's not easy for them to go to hospital. It's also not easy to get some of the medication because not every country has everything in place. Not everybody has a lot of money. And this is what we see. Anybody want to say?
I have to comment. First, thank you for the lecture. It is very collective, full of knowledge. It looks for education of the patient, how to do exercise and rehabilitation. We are concentrating in treatment of heart failure on rehabilitation program. So your advice the patient to learn what to do is exactly rehabilitation. So you like to involve rehabilitation program in your treatment of heart failure patients?
They have all the studies you see, right? Whenever you find research studies, they always say it works. You know, rehab works. But this is the amount of resources, $100 million to run a study and the resources that go into put into place. Of course it works, educating patients. So the question is, where do you start that education? I think we have to now everywhere start enforcing that, you know, the old way of teaching people about things they need to know for their life and things they need to know which are essential, like, you know, homes things and self-care, morals, those sort of stuff. And health must be part of and parcel of education. And what do you teach them when they things? I think people have to understand if they're going to live lives, they're going to fall ill. And very young, they must know how to engage and navigate the health systems they're living in. So I think the language, the vocabulary, the simple terminology there has to come back like those olden days. You know, I think we've got too much into trying to focus on computers and stuff like that. Kids learn that very, very easily. So I don't know how you get this thing going. It probably has to happen at a very UN type level, because that's where all the socialists are. You know, they will love this sort of topic and push the agenda, but it's not going to happen country by country. That's for sure. Yeah.
Okay, thank you.
Anybody more wants to say something?
Yeah, your mic.